to the other device needs. But then he made a second statement, which I think is very important. I found essential precautions to isolate this room from the main building good for this system, but they can never be as efficient and thorough as where contagious diseases are cared for in separate buildings in conformity with the Public Health Act of that time. And I'll come back to that later. Now, some regulations were set up in order to maintain this isolation, and it was required that all refuse that came out of the nickel wing had to be burned. The house surgeon in the nickel wing was required to occupy a separate sleeping apartment, and the nurses in the nickel wing could not leave to the other part of the hospital until the throat cultures were negative for diphtheria. A very sophisticated set of guidelines. So that brings us to the end of the 19th century. So where were we at this point in time? Well, there are three things that I would like you to speak to based on largely the experience in the first 2 decades of the 20th century. The first thing that happened was that the foundation of the public health system as we know it today was established. Departments of health have been established in many communities because of the epidemics that had occurred in Upper Canada or Ontario in the earlier years. But in 1882, the Department of Health for the province was established. In 1884, the first Public Health Act for Ontario was legislated. And between 1884 and 1889, there were a series of amendments of the Public Health Act that dealt directly with the control and prevention of contagious diseases. So the foundation of the public health system upon which we rely today was laid in these particular years, and that was a very important development. I'd like to speak very briefly to vaccination and quarantine as it occurred at that time, and then I'd like to give you some insight of the continuing nature of contagious diseases as it occurred in the nickel wing. And for this period from 1900 to 1922, I have the admission records and the death records from the KTH archives for that period of time. Now, smallpox was continuing in the province. There were frequent outbreaks of smallpox, and particularly in the latter part of the 19th century, the native people of the West were being devastated by epidemics of smallpox. There's a very interesting book written by Michael Bliss about a major outbreak of smallpox that occurred in Montreal in 1885. And this is probably the last very large epidemic that occurred in Canada, although there were subsequent outbreaks. And what happened in Montreal is that in a very short period of time, a period of 4 months, there was a massive outbreak of smallpox of 3,000 deaths in a very short period of time. And it's very interesting because the background of this outbreak was the fact that the francophone community in Montreal were very resistant to vaccination. And therefore there was a large naive population in Montreal, and when it arrived, it had a devastating effect upon the community. In Ontario, according to provincial statistics, that in the period 1884 to 1904, there were 500 cases of smallpox in Ontario. So smallpox had not gone away by any manner of means. Now, Kingston was in many respects very fortunate. According to the minutes of the Board of Health, who were responsible for the care of smallpox, because smallpox could not be admitted to the isolation hospitals, but was supposed to be admitted to separate institutions. Therefore, the Board of Health had to assume the responsibility for those cases of smallpox that arrived in Kingston. And in the last few years of the 19th century and the first few years of the 20th century, the Board of Health had to deal with 2, 3, 4, or 5 cases of smallpox each year, and they had to find some isolation facilities. The Board of Health was constantly asking for a separate facility for smallpox, and the only real facility that was available was an abandoned hospital, military hospital on the east side of Fort Henry Hill, which had been used by the military when they were still here prior to their departure in 1871. The Royal Military College, continually the Department of War Department, rejected their request for this because RMC did not want to have smallpox in their backyard. So we heard that story before, and it came up again at this point in time. But generally speaking, Kingston was relatively fortunate in relation to the occurrence of smallpox. However, the efforts in regard to vaccination were being vigorously advocated by the Provincial Department of Health and by the municipal departments of health. And in 1897, the provincial legislation required that the council of each city and town be empowered and required to contact with some legally qualified, competent medical practitioner for vaccination. That extends to the municipality for the poor and for those who could afford to pay. So they were very active in regard to creating the opportunity for vaccination. But we must remember there always was and always has been an anti-vaccination lobby. And I don't know whether anyone heard the news last night, but the Supreme Court in the United States rejected a request by a vaccination group to sue the pharmaceutical company because of complications due to PCP. So the issue is that the community was actively endeavoring to assure that vaccination was available and was practiced as widely as possible, because they viewed it as the best way to eliminate the problem of smallpox, which ultimately proved to be true. Now, in regard to quarantining in contagious diseases, the same kind of legislation was occurring, and in 1899, the Board of Health in Kingston established this requirement. Whenever a case of contagious disease exists in any house, the host holder shall, within 18 hours after the time such disease is known to exist, notify the head teacher of such school and also the secretary of the local Board of Health. And no member of such household shall attend school until a certificate has been obtained from the medical officer of health or a legally qualified practitioner that infection no longer exists in the house. This is a very high level of community quarantine. And some of us may well remember the fortunate sons who were in the house with a card in the front window that they couldn't go to school because they had chickenpox or smallpox or chickenpox or measles or something like that. A practice that did continue for a long time that's turned into today. So at this point in time, a very high level of quarantine was being established within the institutions and within the community in regard to contagious diseases, the diagnosis of which were much more highly recognized. Now, there were a number of contagious diseases that continued in the first 2 decades. And this reflects the experience in the nickel winning between 1900 and 1922. Typhoid fever is characterized by fever and diarrhea, and during the 19th century, throughout North America, the mortality would range from 5 to 20%. The issue of the cause of typhoid fever had been, the source of typhoid fever had been identified by William Budd in 1856 in an epidemic that occurred in Bristol, where he concluded the disease was due to fecal contamination of water. And the end result was that there was an understanding of the enormous importance of clean water and the potential, in the absence of satisfactory sanitation, to have polluted water. And pollution occurred either from cities, through wells, or from the influx of pollution into our rivers and lakes from which the source of waters were being drawn. In the nickel winning between 1900 and 1918, I don't have the emission records for 1920. It's an interesting story if you're in archives. But these are the admissions that occurred each year over that period of time. There was a total of 861 patients admitted with typhoid fever, averaging about 45 per year. The mortality was particularly significant in relatively young adults and ranged from the age of 10 up to 40 years of age with some older patients. The mortality in that period of time due to typhoid fever was about 6%, which was pretty good in that particular year. There was a great recognition in the community by the Board of Health in regard to the importance of water and sanitation. And if you read the minutes of the Board of Health for Kingston from 1895 to 1915, there isn't a single meeting that they didn't talk about water and sanitation. Now, the Water of Kingston was a private company was commissioned in 1849 to establish the pump house where the current pump house is. And it operated for a number of years relatively unsuccessfully to serve a very small part of the community. And in 1887, the city purchased the pump house and actually enlarged it. And this is the pump house that we know of today, which is a product of the enlargement that occurred in 1887. When they were finally beginning to bacteriologically test water, because that was possible, they established in 1894 that the intake pipe was drawing water from polluted water. And so the intake pipe was extended another 1,700 feet in an effort to get out to cleaner water. The Board of Health didn't have a meeting, but they weren't required to review a well in the community and establish that it was polluted and that it could no longer be used. There was a very interesting detective story of typhoid fever that was a product of milk. And they traced the source of the typhoid back to the well that the dairy was using in the production of their milk. At the same time, there was not a meeting of the Board of Health that did not discuss some major deficiency in the sewer system and submit a request to the city that something urgently be done in an effort to improve either the linkage to the houses or the drainage of this sanitary system. So the level of concern in the community was very high. Now, diphtheria was a disease that many of us probably never see today, but associated with fever, sore throat, and difficult swallowing, was endemic in the 19th century and was associated at that time with a very significant mortality of about 15 to 30%. Scarlet fever was characterized by fever, sore throat, red tongue, and a rash, and again had a mortality in the 19th century up to about 10%. Now, this is the pattern of admissions of diphtheria in blue and scarlet fever in yellow. And it's evident that there were outbreaks in different years of these two diseases, and they cycled up and down. So during this period of time, there were 898 patients with diphtheria admitted to the hospital, averaging about 47 per year. Scarlet fever, there were 645 admissions during this period of time, averaging about 34 per year. So it was a significant problem that the isolation facility was required to deal with. Now, the mortality due to diphtheria and scarlet fever was almost all restricted to infants and young children. The vast majority of the mortality in diphtheria and scarlet fever were in infants and small children. The mortality rate in diphtheria for those patients admitted was about 4%. And that really was quite good. And that probably was a product of the fact that the diphtheria antitoxin had become available in 1895 and was being used in the treatment of diphtheria as long as we saw the patient early in the course of their therapy. The mortality due to scarlet fever was about 2%. Now, influenza is a disease that we're all familiar with and various manifestations, and it too occurred repeatedly throughout North America. Kingston did not seem to be seriously impacted, at least to the level requiring hospital admission in the early part or the first decade of the 20th century. However, in 1915, there was a surge of influenza admitted to hospital. In that period of time, although the number of patients admitted were becoming significant, in fact, there was no mortality. However, in 1918, between